So I'm Etu, I'm an old age psychiatrist. And what I want to talk about today is using routine data, particularly InterRAI and other health data sets, to try and estimate things like prevalence and incidence of dementia in New Zealand. And one of the interesting things about it, particularly building on the first talk this morning by Sarah, is there's a big question about who we're actually missing and who's not actually appearing in any of these data sets. So that was kind of the impetus for this. And I've got Gary and Sarah in the room, who are my supervisors. Oh, and Nairi. Yeah, we'll see how we go. So just to make the point that actually since 2008, the economic reports come out with prevalence numbers, and it keeps on saying that there's a tsunami of baby boomers hitting retirement age. Prevalence of dementia is going to shoot through the roof. And when we did our report a couple of years ago, it's been quite clear that actually, as of 2011, the first of the baby boomers started hitting 65. So in 2023, 2024, we're at the height of an aging population. And that wave is going to shoot through to about the late 2030s, early 2040s. Which means that our numbers for prevalence of dementia in New Zealand, look fairly dire. We're sitting, based on the current estimates, at around 75, 80,000, and it's going to hit about 170,000. The issue is, though, that those numbers that our prevalence estimates are based on aren't really representative of Aotearoa's population. We had a small study by Professor Campbell back in 1983 in Gisborne, but other than that, the other three studies that prevalence estimates are based on are, Canberra, which is nothing like New Zealand, Hobart, which is even less like New Zealand, and then the Kimberley was actually a study of about 300 Indigenous Australians, Aboriginal Australians. So clearly the current data probably isn't fit for purpose for us. So what Catherine Walesby did in 2015 was her group basically took the mortality data set, the pharmaceuticals data set, and public hospital discharges, and they had a look at how many people were identified with dementia after linking those three together. And then Gary's group, a couple of years ago, added in 4 more data sets, including the InterRAI, to see what, to see what the prevalence of dementia looked like. Now, one of the problems with using routine data is that you're not picking up everybody. So what you can see on the graph here is that the ADI estimates from 2015, which is what the dementia report's based on, says we have about 70,000 people with dementia in New Zealand in 2020 at a rate of just under 7%. Interestingly, Campbell's 1983 study found a very similar prevalence, and that's only in the over 65s. But then you look at the two on the right there using routine data, and the prevalence estimates are a lot less because they're just not capturing everybody. So the question then becomes, how can we account for the people that are missing? And one of the ways that you can do that is by modeling the data to look at how the data sets interact and to look at whether you can estimate box H in the corner there. So in order to appear in, say, the InterRAI data set, as Sarah was saying this morning, you have to have had an InterRAI assessment done. There has to be a diagnosis of dementia coded in that data set. And the same goes for anti-dementia medications. Oops, it says pharmaceuticals twice. And public hospital discharges. So you have to have a diagnosis, it has to be picked up, and it has to be written down. And those 3 things mean that we're missing a lot of people. So basically what we've done, along with Dan Davis, who's a gerontology professor in the UK, and Naheed Mukadam at UCL, is that we've done what they call log linear modeling, which is effectively a fancy way of saying, this is how the 3 data sets overlap. Those numbers there are the number of people with dementia picked up in either the data set itself or in the way that they overlap. So for example, in the top middle there, we picked up 11,206 people with dementia who appeared in both the InterRAI and the public hospital discharges. at some point prior to 2021, and they were still alive in 2021 and in New Zealand. And basically what the modeling does is just looks at the overlap between these. It models 8 different models, and then you select the best fitting model, and that gives you your numbers. So what you can see here is on the right there is our modeling for dementia prevalence in the over 60s. So we picked up a shade over 3% of people, much like Gary's group did next to it. But then when you model for the missing cases, we've kind of shown that about half of the cases of dementia in New Zealand are probably being missed. And what's quite reassuring from the data is that our modeled estimates are actually looking reasonably similar to what the ADI was estimating anyway. On the left there is the model data by ethnic group. We know that Māori Pacific people in particular probably carry a higher risk burden than modifiable factors for dementia. And we know that their population is aging a lot more quickly in the coming years, so they're going to carry a much bigger burden. So on the left there, we've got the modeling data by ethnicity. Yes. Yes, sorry, yeah. That's prevalence. Prevalence percent in the over 60s. Which bar, sorry? Oh, so blue is the actual ascertained cases that are in the data sets, and then red is what you end up modeling. Oh, sorry. Oh, sorry. Māori, Pacific, Asian, European. My apologies. I work on a Mac and it doesn't transfer particularly well to PowerPoint. And on the right there is Gary's work. Basically, once you standardize for age and sex, showing that, Māori and Pacific on the left there of his graph are sitting at about 1.5 times the prevalence of the European population, which means that our findings are probably a slight underestimate. Pacific and Māori populations are younger. Dementia is primarily a disease of older people. So actually, if you standardized ours, which we weren't able to do because the numbers get too small, we'd probably see an even bigger differential prevalence between the ethnic groups. So what I really wanted to do was an incident study on dementia and to look at risk factors for dementia and how they are translated through to a diagnosis down the line. So what we did was we've taken 8 years of the New Zealand Health Survey as a nice cohort of people who generally don't have dementia. We followed them through over time, looked at them in all of the 7 data sets to see whether they received a diagnosis of dementia at some point in their follow-up period. And much like the prevalence study, we end up with about 1,800, 1,900 people with dementia in that cohort of about 70,000, followed for an average 6-7 years. And we've repeated exactly the same process of log linear modeling. So if you look at it by age band, what we can see here, so in red is our modeled numbers, and then all of those other bars are different incident studies from around the world. And what you can see is that even our modeling shows that we're coming in within reason with what everyone else is estimating. In fact, as you get to the older age groups, we're probably modeling a bit lower than what other countries are finding. And that's just a comparison between our model data and the ADI global data, and then the ADI high income countries that we want to compare New Zealand to. And again, what you can see is that the modeling is slightly higher in the lower age groups, but as you get to the 85, 89, 90 plus age groups, we're not even estimating as many missing cases as other countries are. So in real terms, what does that mean? It means that we are estimating about 18 people per 1,000 over the age of 60 developing dementia every year in New Zealand, and about 22.5 people over the age of 65 per year developing dementia in New Zealand. And what you can see there is that these estimates are roughly in line with things like the ADI estimates or the cognitive aging study from the UK. We've shown that, sorry, again, Maori, Pacific, Asian, European, that there's actually no difference, no statistical difference in the incidence rates between Maori and Pacific and European. But even with modeling, the Asian population is still being undercaptured. And that's partly a reflection of the modeling, but it's also partly a reflection of the fact that they're just not engaging with these data sets the same way. So we are missing a lot of the Asian population. So in real terms, that means that in 2023, we'd be expecting about 21,000 people to develop dementia over the age of 60, and about 19,800, 20,000 people over 65 every year developing dementia. And that kind of fits with the prevalence estimates because the, mortality after diagnosis of dementia is about 5 years on average. So 20,000, 5 years, that's about 100,000 people with dementia. So even our best estimates from the economic report a couple of years ago is probably underestimating dementia in New Zealand by about 15, 17%, particularly if you look at the modeling for the over 65s, which means that in 2025, we probably have about 90, 93,000 people with dementia in New Zealand, and we're getting about 20,000 new cases every year. But more importantly is the question of who we're missing. And it looks like we're missing about 30% or a third of all new cases. And actually the data sets that we have are only picking up about half of our population with dementia. Part of that is because, as someone mentioned earlier, primary care doesn't code their data. So potentially that would add a few more cases. But at the moment, with the 7 data sets that we have in the hospital system, we're missing about half of all dementia cases, which is why my focus for my research is really around prevention. Thank you.
Thank you. Hi, thank you very much. And it was so relevant. One of the things we noticed when we tried to do different research questions around dementia in the general hospital discharge data set is that frequently BPSD may be coded without dementia. So, people come in from rest home or from their GPs or wherever, and they are diagnosed with BPSD, but the word dementia actually does not come up as a primary diagnosis. So maybe that's something to look at the discharge data as closing the gap in a way.
Thank you for that. It's really fascinating and worrying, the numbers. You did make the statement that I might not agree with, that GPs don't code their data, because some GPs, or many GPs in the South Island at least, code their data using read codes. Some practices are exemplary and have extremely detailed and reliable coding. So you've got an opportunity there to at least work with the willing to look at some population work from general practice.
Yeah, apologies. What I meant was, even if primary care code, it doesn't end up in any of the national data sets at the moment.
Ulrich Birchler from University of Otago. I may have missed this. Do in part you answered it just before. The data that may have dementia diagnosis in it, you can't access, or it doesn't end up in the prevalent. But what's the ratio of people who are actually undiagnosed and out in the community with dementia?
Based on this,
Yeah.
it's about 50%.
Okay, so that's the number you derived, that the undiagnosed. Okay, thank you.
Yeah, I mean, look, it is statistical modeling. There is probably a bit of an error balance to it. But what we know is that even with the 7 data sets, Gary's work picked up about 40,000 people. I don't know with the overlaps how many more primary care would pick up, but I'm guessing it still wouldn't hit even a conservative estimate of 75, 80,000 people that we estimate are in New Zealand with dementia anyway.
Thanks, Sarah Cullum, University of Auckland. Well, just to come back on that, I mean, in the UK, because there's a financial incentive to diagnose dementia, they have actually looked at this, like the expected numbers and then the actual numbers on databases. And it was about 50%. I think it's slightly better now because of incentivization. So, that is similar to elsewhere. I just wanted to ask you, because you said that you couldn't age standardize because of the numbers. So do you think that the predicted numbers may be even higher than what you've put here?
No, so you can, well, for the total 60 plus population, it's fine because that's the entire population of New Zealand. What you probably can't do with that number is extrapolate over time without age bands. So I think the total population estimates are fine. The difficulty with Māori and Pacific populations in particular, because they're younger, is that you'd have to model every age band and then age standardize after that. I've done that, but because the numbers get so small, particularly by the time you have to split it into 8 different categories, that the confidence intervals become really, really wide, so they're almost meaningless.
Hi, thank you for that. That was really interesting. I just wanted to clarify, so with your definition, so you're picking up incidents, so first event, and it's diagnosis apart from the pharmaceutical data, is that correct?
So in this case, it's either a diagnosis appearing in the InterRAI data, or it's a diagnosis being coded in hospital discharges, or it's someone being prescribed anti-dementia medication, because you can only get those if you have dementia. Oh yes, so there are 7 data sets that are used. So Gary's group used all 7. It's very difficult to do this modeling with more than 3 data sets. You could potentially do it with 4, but then you're looking at 20 or 25 different groups that you're slicing and dicing, and the numbers just get too small.
Okay, thank you.